Want to welcome you to Healthy Seminars. My name is Lauren Brown. I'm a doctor of traditional Chinese medicine here in Vancouver, AcuBalance Wellness Center, and I'm your moderator. And today on Healthy Seminars, we're going to have a presentation by Dr. Steve Shomo and Dr. Valerie Hobbs on best practices for acupuncturists going back to work. And before we bring the speakers in this informative lecture, I'm just going to do a little bit of housekeeping as we become accustomed to here on our show. So on Healthy Seminars, if you go to the resources or healthyseminars.com/resources, this is where you'll find the calendar of events and links to certain topics. So for example, here we are on May 8th. So if you wanted to come and revisit this again, when the recording's up, you can click on this link on May 8th and it will take you to the replay. So this is how you can find it. Also, if you go up to this area and you want to see all the stuff on TCM knowledge and COVID-19, you click on this and it'll anchor you down to another page section on this website. And then it'll tell you how to get to the replays as well. So we have two ways to get it. If you remember the date, you can go that way. Or if you want to see all the stuff that's COVID-19 related, you can click here. And as you can see, we have different topics. And we've been doing this since March 24th, 2020. We've been around for a long time, but we started this community unity immunity logo, and this idea is we wanted to create community when isolation started. And so we started a series of lectures, and they grew to 1 to 2 a day since March 24th. And the idea was to bring us together. So although we were doing physical distancing, we could have social solidarity. And we also wanted to fill you up with good knowledge. We wanted to inspire you and keep your brain sharp and have you come together in a community and learn, and to feel inspired versus watching the news or worrying about all the bad things that could happen. We wanted to give you uplifting and positive information. And so thank you for our tribe for coming on a regular basis. Here's what's happening over the next little while. And I will mention on the calendar, if you want to see anything you missed in April or March, just click the previous and it'll take you to the previous month. And then you can see if that replay is still available. Next week, we have a webinar on sex drive and hormones, how do you make a baby when you're not in the mood, by Dr. Carrie Jones. And she was originally going to do a talk similar to that at the Integrated Fertility Symposium, but since it was canceled, she's doing it here on our resource page. I'm doing a workshop over 4 days, 2 hours a day. You can watch the free introduction to that as well. And then on the 22nd, we also have maintaining immune integrity with botanical formulas. So they're going to talk about gut and respiratory health. So you may find that of interest as well. And as you can see, we have a lot of still lectures available to you. All right, let's go back to our lovely people and what we're going to do here today. So on Healthy Seminars, as I shared, we have a lot of resources for you. And our goal at the time, back on March 20th, when we started this, was just to create as many free resources as we possibly can. And we still had our live upcoming CEU-approved courses. So we've kept those up, and we kept the early bird discounts going throughout the month of May as well. So we did not have any of our early birds expire. And all of our courses on demand we put on sale for the month of April, and we've continued that for the month of May because some of you still want or need to do continuing education. And so if you're looking for those CEUs, I want to let you know that the coupon has been extended to the end of May for you based on your request. And that coupon code is HEALTHY25, and that'll give you 25% off of everything on demand. And all the upcoming live webinars, the coupon does not apply to that because they're already discounted at 25% or greater. And we're going to keep those like that for the month of May as well. A big thank you to my team and for you guys coming with your questions. So I just want to thank Sandra and Lorianne because they have been working really long hours since March 20th when we came up with this plan to create community and information for you. So thank you to the team. And then for all the amazing speakers that have come and I know are planning to come, including Dr. Stephen and Valerie today, volunteering their time. It's just greatly appreciated. If I can have the disclaimer slide, I'll also just share a little bit about our speakers as well. So just to let you know that this is for educational purposes only. This is not medical advice. This is not to be intended or interpreted as medical advice. If you have a health condition, please seek out a healthcare provider, and please seek out your health authority, your government authorities in your own state or province for what is required for you. So our topic today is best practice guidelines for acupuncture clinics, reopening after COVID-19, stay-at-home orders. And our speakers today, we got Dr. Valerie Hobbs. She's been in practice, sorry, I just lost my notes here. She's been in practice for over 25 years. She is currently the director of postgraduate doctoral programs at the American College of Traditional Medicine at the California Institute of Integral Studies, where she is also an associate professor. And since 2008, she's been the co-chair of the Clean Needle Technique Committee for the Council of College of Acupuncture and Oriental Medicine, and is the lead author of the April 30th CCAOM Clinic Infection Control Advisory. It's an advisory on infection control design making for acupuncture clinics during the coronavirus epidemic. And then Dr. Steve Shomo, he's a doctor of acupuncture and oriental medicine. He's NCCM board certified and dual licensed in multiple states. He's an international leader and educator in the field of integrative acupuncture with over 20 years of clinical and academic experience. He has completed postgraduate studies in Japan and in the United States with specializations in oncology, disaster mental health, so traumatic stress and PTSD, very relevant now because of what's happened with COVID and the stress response for people with respect to that. Also in public and global health, auricular acupuncture, pain management, acupuncture injection therapy, dry needling, laser biostimulation, TCM sports medicine, and performance, emergency, and disaster response. Dr. Shomo is a wilderness first responder, instructor, certified strength and conditioning specialist, Colorado Special Tactics and Rescue Team volunteer, and the training and logistics coordinator for the Colorado Acupuncture Medical Reserve Corps. It's the nation's first acupuncture-based federal-approved MRC responding to disasters and critical incidents. Dr. Shomo is VA provider and is credentialed and holds numerous local hospital privileges, providing both inpatient and outpatient care. So he's in a hospital setting. He's faculty for several DAOM and master's program, and he's served and continues to serve on various state acupuncture and global health association boards. And as a subject matter, he's an expert for veteran administrations, the VA at the Department of Defense. So basically, this tells me that if I'm going to go on a wilderness trip, I'm taking Steve and Valerie with me. And that's how I feel safe, because you guys, you're set. You were in good hands with you guys. So without any further ado, I think Dr. Steve Shomo is going to start. And if you guys have questions, the audience, raise your hand, and we'll get you definitely by the Q&A time. I'm looking forward to this talk.
Great. Thanks, Lauren. I hope everyone can hear me at this point, and thank you, everyone, for joining us today. We know this is a trying time for everyone, and we want to get back to work economically, but we also want to get back to, treating the patients and the people that we can help out the most. So hopefully this next 60, 90 minutes that we spend together gives everybody an opportunity to get their questions answered in regards to how we do that in this trying time that we have. Let's see if I can get the slide to switch. There we go. So the first thing that I want everybody to kind of remember, I know we all come from different backgrounds. We all come from different types of practices. We all have different reasons for wanting to get back to work, whether it's from economic or even down to our own mental and physical well-being. One thing we want to remember through this entire process is that we took an oath originally to do no harm. And that's one thing we always want to keep in mind and understand through this entire process. We want to keep that in the forefront of all we do. One of the key factors, we're all in different locations. We have different governing bodies. The key thing for you to understand and know is who governs what you're doing, or whether it's opening, your licensure that's there. Most of the time in general, regardless of whether we're talking tribal or we're talking national components, your local health department is going to be the one that dictates when you have that ability to reopen. So for here in Colorado, it goes down to a local standpoint. We have various counties and cities that are opening up at different times. So it's very important that you do know when you have that authorization to reopen, as well as when you are ready to reopen. And hopefully we'll be able to help prepare you for that. So always we'll give you some breakdown as far as the locations and who you can contact with links to find out what governing body is going to be best suited to give you that information. Most of the time you'll find this is from your public health authority, and they will have the jurisdiction even over as far as what you see nationally. So you need to learn to follow that local guideline first and foremost. This slide will provide you with some resources from an international perspective with the World Health Organization, as well as the CDC guidelines. Then as we get down into the United States here, you have a state-by-state ability to log in, as well as a county health department resource that will allow you to take a look and find the governing body and determine what your date to return to work is from a legal standpoint. At this point, before we move forward, I'm going to let Valerie take a little bit of control with this, go over a few guidelines from a perspective there, and then we'll get back to doing PPE with me.
Thank you, Steve. I'm just waiting technically so that I know I have control of the slides.
You may have to double click on the slide itself to give you control.
Thank you.
There you go.
The C&T committee issued 2 advisories during the pandemic. One was early in March when practitioners were considering whether or not they should close their offices. And we just sent out another advisory at the end of April with some details about how to structure your clinics and how to come into a decision-making process about reopening. Let's go back one. Here we go. And I want to put us on the same page about what we really know. Because we have been staying at home, and now in many jurisdictions we can begin a limited amount of going back to work, that hasn't changed the nature of the infection, and it hasn't changed the virus. And in fact, some of the information that is going to come out as we learn more about this virus is that it is likely that the virus was being spread in the community, which means that the source of the infection was not necessarily from direct contact with a person who was ill with COVID-19 before some of the documented first cases. So we know that this is a virus that does spread mostly from close contact, but also perhaps by surface contact. And we need to keep that in mind as we do our thinking about how to reopen our clinics. I'll repeat what Steve said here, that it's really our duty to keep the community safe and to follow directives from public health and to do no harm. So what do we do about it? Because in faced with a novel virus, a novel mode of infection, many things that we don't know, it seems somewhat overwhelming, but there's a lot of things that we can do. And our intention here is to give you a process as healthcare providers to give you confidence in the training that you already have, and give you a few decision-making points about how to integrate the information about the infection controls that can be put in place for this new situation. So the C&T committee of the CCOM issued an advisory, and the advisory encourages practitioners to set up, first and foremost, a safety plan. And in that safety plan, what you have to do is look at your physical settings, look at the availability of personal protective equipment in your community, and then to create disinfection procedures and infection controls. In the United States, where we are healthcare providers that are under OSHA regulations, even if you're in a practice of one, You are required to have an infection control manual, and this has been, in our profession, mostly about bloodborne pathogens. And once a year, you should, even if you are in a practice of one, sit down with yourself and conduct a safety meeting and look at your processes and look at your procedures and revise them as necessary. So this is a perfect time to begin to develop that document if that's not something that you have done before, and then to revise the document. And in many jurisdictions, what regulatory agencies are looking for is that you actually have these written plans, and sometimes they're mandating it. So now it's time to make a safety plan and to use your good clinical judgment. You are accountable for your decisions, but you're also completely able to make these decisions. And when we did our advisory back in March, one of the things that we did is that we reached out to the college clinics, and we reached out to a lot of different kinds of providers. And one of some of the inspiring thoughts that we got were from community acupuncture settings. In particular, I want to thank Lisa Rettler for her contributions in terms of thinking about what do we do now. And at the fundamental level, when we are looking at studies and our training, we need to be able to trust that we do know what to do and that we do keep our best interests and the public's best interests at heart. And that if we come from that place, we will create protocols that are going to be the best guidelines that we can come up with at this time. And then we will stay informed and revise those guidelines as more things are known. Also, at this time, the entire world has experienced some amount of disruption and even to trauma and perhaps grief in an extraordinary way. And in a situation, as you know, as practitioners, where you are in the midst of dealing with this kind of background on yourself, it's important to be able to fall back on processes that can help you keep one foot in front of the other. And so we want to recognize, even as we're going through protocols that seem daunting, that we do recognize that there is a mental and emotional health component to what we're doing, even for ourselves. So the requirements to open, really, the requirements are you should open only when there's an officially announced date. In some jurisdictions, the local dates are different from the national or larger state or provincial dates, and that's because they're being rolled out while information is rapidly changing. So in your particular jurisdiction, as Steve said, you really need to pay attention to the local authorities, but you also need to opt for the latest date. So if you're getting one date from local and one date from state and one date perhaps from a licensing bureau, and they're all different dates, the latest date is the one that should rule. And then you should default to the local authorities. And you should only open when the requirements for opening can be fully implemented. And you should only open when you can safely reopen. And you should open when you choose to reopen. Okay, so here's some recent facts about the virus. And of course, we're a little bit on the bombarded side with a lot of information. And so as healthcare practitioners, what we tried to do with the CNT advisory is that we tried to make it as evidence-based as possible. So many of our sources for the information are going to be major medical journals and government agencies. What we know now about this virus is that it is shed in high concentration before symptoms appear. There has not been a definitive study showing that people actually caught an infection from someone who was asymptomatic, but that's going to be very difficult information to capture. What we do know is that people have been confirmed as ill with coronavirus, and they have no idea where they came in contact with it. And then this first study at the bottom of the slide, the ERYT study that came out in the New England Journal of Medicine, that study was on in a nursing home in Washington State. And what they did was they, at the first official word of an outbreak in a nursing home, they tested 89 residents in one wing of the facility where the outbreak started. And they cataloged how many of them were positive for the virus and how many were symptomatic and asymptomatic. And then they came back in another week and they redid the testing. So this is one of the first places where it was an enclosed population of at-risk people, and they tested everybody. And what they found out in this facility is that a little over half of the people who tested positive did not show symptoms. And about 89% of them did develop symptoms within somewhere between 3 to 7 days, with a mean of 4 days. This is a contained population, an at-risk population, and to compound things a little harder, about half of the people who were asymptomatic also had cognitive deficits. So you have to take the data with some limitation. But it was a pretty decent sample of testing everyone and then looking prospectively at what happened. So we know that people are shedding this virus. The shedding is coming from the upper respiratory tract. It's really coming from the nose. In influenzas come from the lower respiratory tract with coughing. One of the reasons that it spreads a little bit faster is the wrong word, but it's a little bit more contagious because coming out of the nose, it just spreads a little easier. So when people are wearing face masks, you have to be careful to keep it fitted well over the nose in order to not shed the virus. When we advise screening, which is very important, and I have I've certainly been in around a college situation where people come in and they feel fine, but they have a temperature. Screening is really important and symptom tracking is really important, but it's not adequate in and of itself. And so we at one point thought that that was one of the ways to prevent the spread of the virus, and now we know that it is not. So the guidelines are that face masks are required in healthcare facilities, and we're going to talk a lot about why that is and what kind of face masks and what you need to do. So to talk you through this process, a lot of what we're going to give you some facts, but also what we're going to give you is a process that you can take away and use because all your settings are different and your practices are different, and you're worldwide in different geographies. And so you have to look at your own situation and be able to apply basic principles. So you want to look at your setting, and particularly the entry to your clinic space. And that even means the entry to the building in which your clinic space is housed. So if you're in a clinic that is down a corridor or up an elevator, you have to take into account how the patient may enter the common building and your own clinic. You want to think about the setting of your treatment space. What is it like? How big is it? Is it well ventilated? Are there multiple treatment rooms? Does it have narrow corridors where people have to come in close contact with one another in order to pass in the space? You want to think about a dispensary area, and then you want to think about your staff area because it's important that you protect your employees and yourself if you're the employee. And so in this office space, you're going to analyze how your setup is in order to accomplish screening and social distancing, hand hygiene, cough hygiene, and surface decontamination. So the screening actually begins before somebody walks in your door. It begins with visual and audio alerts on your website, in your voicemail, on posters, on a sign on your door, as you're returning phone calls. You really need to alert people to what's going to happen when they come into your opened clinic. You need to alert them that symptomatic or positive patients probably should not be treated on your site unless you are in a clinical setting in which that would be appropriate. And you need to alert them that you will be putting in place social distancing procedures, and you need to alert them that they should bring a face mask with them, or that a face mask must be worn in your clinic. And then little things like we're going to advise you to try and get away from ever having somebody take a pen and sign something if you can, but if you can't, then people should bring their own pens with them. And if that doesn't happen, you should be prepared to give them one. You shouldn't be reusing them. Okay. So screening upon entry, and this means entry into your space, not that somebody walks across a waiting room and comes up to a front desk and then you do the screening. But you need to be prepared to do screening before someone ever comes into a space where other patients may come after them. So you want to screen upon entry, temperature, symptom questions. You want them to perform hand hygiene pretty much on the spot and provide a face mask. And Steve will go into some detail about what those screening questions are in a little bit. And then the social distancing things, when we first wrote this advisory, we weren't so familiar with them, and now we're familiar with them all over the world. It is in your treatment spaces, you need to keep a minimum of 6 foot distance between your patients. And for your staff, that includes any staff members who may be working in a dispensary or at a front desk. And you need to enact procedures to ensure that distancing.
Valerie, could you go
Yes.
back 2 slides to the screening? I just have a clarification on the screening slide. So what about some spaces where they wouldn't really get into your space until they're already in the building? Like it's kind of, you're not like at a storefront idea. Mm-hmm. So just on the practicality for this screening, you think there's an expectation that we're going to have somebody like sit outside a building to screen people, or once they come to your waiting area, if that's the only practical place that you would do the screening? Because some places your physical layout would make it pretty challenging to screen them before they make it to your waiting room, for example.
So this is a great question, because it brings up the fact that this is not a hard and fast guideline. This is sort of a recommendation guideline. In some places, depending on the foot traffic and the way that your clinic is set up, what we're suggesting is that, and I'm going to talk in detail about this, like patients shouldn't come into a waiting room. And so you may have procedures where your patients are doing a virtual waiting, if it's safe, for instance, in their own automobile or at some distance outside. And they shouldn't just be walking into your clinic. So theoretically, they will notify you that they're in the area. And then theoretically, you will have a mechanism for being able to get them into your clinic. And so there's no expectation that you're going to do the screening before they come into the building, but that there is a safe way to conduct them from point A to point B and then do the screening. So the screening is really at the entry to your actual clinic space. Is that helpful?
It is. And as a follow-up, if somebody comes to your clinic and they have a mask on, or as soon as you start to screen them, like say you take their temperature, you're going to give them a mask. I know you're going to talk about this later, but just the risk of infection, just because you take somebody's temperature and their temperature is elevated, that does not mean you now have COVID yourself. Just to put clarity, right? You're just screening.
No, it does not mean that. But it also means that and just because someone has a temperature doesn't mean they have the COVID infection. So people do get temperatures for other reasons. However, we can't currently screen for that. And the virus is such a tenacious spreader that at this time, and I think Steve will go into some detail, we're recommending that you really shouldn't be treating people who are have those symptoms, whether you can confirm whether it's a COVID-19 infection or not.
Great. Thank you.
Yeah, you're welcome. Great questions. Okay, to further practice social distancing, we talked a little bit about this. You may consider using telehealth or phone intake as much as possible. So again, if you can set it up, a possible scenario is that someone alerts you that they're in the area. You do the intake on the phone, a distance. They don't even walk into your clinic while they're talking and you're talking, as much as that is practically possible. And then they wait in the car until they can be taken directly in the treatment room. So what we're trying to do is that we're trying to analyze your settings so that you're minimizing the amount of time that somebody who may be potentially infectious and they don't know it and you don't know it, that they are moving through your treatment space in a very limited way and getting into the treatment room as soon as possible. This also means that people who accompany your patient may have to also wait in this virtual waiting space as long as it is safe to do so. And this is part of the visual and audio alerts that you should give your patients, that you request that they really do not bring people who are, this word has been a little overused, that are not essential for the treatment itself. Sometimes people need to be accompanied because they are frail or they need assistance getting into a space. But for the most part, we need to instruct our patients that they should, if they can, come by themselves to the treatment appointment. If they do come with someone else, that someone else should make sure that they're comfortable in the treatment room. And if they, if needed, and they need to be with the patient at all times, then they should stay in the treatment room. They shouldn't be in the waiting room or going about the clinic, or that accompanying person should go back to the virtual waiting space and not wait in the waiting room. You may have to physically mark your space. It depends on the traffic, just like they're doing in most grocery stores. And you can consider the curbside delivery of herbs. So if you're treating and then you typically do a prescription, your patients shouldn't be waiting anywhere to pick up that prescription. They should, again, go outside of your clinic and then arrange for curbside pickup. Okay, in terms of the hand hygiene, you should provide some posters on hand hygiene. It must be carried out by every person upon entry in the clinic, so you should try to avoid the situation where you're walking them into a treatment room where there's a sink. They really need to do that hand sanitation a little earlier. So that means you have to, in many situations, you're going to have to provide some hand sanitizer. And it should be in multiple places or immediate access to soap and water. There is some guidance by the CDC now that they really feel that using hand sanitizer is showing up as being a little bit better because people's practices of washing their hands for enough period of time and covering all the surfaces of their hands it's on a continuum of being sometimes just fine and sometimes not. And so the CDC is kind of saying this hand sanitizer does a better job overall. And you should always be practicing hand hygiene as according to the C&T manual. By the way, for those of you who may not be familiar, the manual that I am referring to is available on the ccaom.org website, and it is the manual that is used as standard infection control for acupuncturists. Okay, cough hygiene. So posters on cough hygiene, a really good place to get these posters are from your local public health department. Many of them have posters that you can download and print. So when people are in your site, you need to provide some tissues and no-touch waste receptacles so that tissues can be discarded and they're contained in the waste receptacle. The lid to that waste receptacle needs to be cleaned frequently. just to keep that in mind. And if people are wearing a face mask, that should contain some coughs. So, but you still should have tissues throughout your facility. There has been some good conversation about ventilation and the need of ventilation. And so I put a link here to a publication about ventilation, but frankly, there's some, I actually thought one of the better resources I found was from the European Union on what ventilation should be. And some of the guidance is about people who are in office buildings where there are large HVAC systems. And there are professionals who have to sort of look at ventilation rates and outdoor air rate. And the idea is that this is a virus that you get from the spread of droplets. And it seems pretty clear that it's a droplet transmission. So when somebody coughs or they sneeze, they may spread droplets that have the virus about 6 feet. And although there is some information that maybe it will stay in the air a little longer, and in some rare cases, those situations are really tested out with people who are infectious, and procedures are being done on them that aerosolize, like you're intubating them or you're doing CPR on their chest. And even the studies that came out recently about, oh no, it aerosolizes and it's in the air, were done in laboratory conditions that mimic those situations that would be in an ICU. And you're probably not going to, encounter in your clinic's situation. But we need to be mindful that when people are talking and singing is one of those things where people are projecting their breath and droplets into the air, and running and any aerobic activity, then the spread may go a little bit further. So the idea is with good ventilation that you, in the rare cases where the droplets are going a little further, not so well contained, you're bringing in enough clean air and you're circulating it well enough that you're actually diluting any of those rare droplets that might be airborne. And so that's the idea behind that. It's not the typical route of infection. And so I think we need to practice some good judgment on whether we're going to start buying filters and whatnot. HEPA filters may not filter out the small micro droplets that this virus is. So I'm not an expert in air filtration, and what advice I can give you is that you need to look at your setting. If your treatment room's all completely enclosed and have no air, that's something you need to think about. But here's the other kicker, is that if you run a fan, there has been demonstrated that people actually got infections from being in air conditioning that was directed in a large room. So it's a fine balance between having clean air coming in and filtering the air to kind of dilute any kind of virus that may be in the air, and not creating more surface where infectious droplets might land because you're blowing a fan into a room. The best way to really help the spread of the virus, and according to ventilation, is to make everybody wear a face guard, honestly. It's not foolproof, and there are some criteria here, but it's just part of your thinking. And then you might think about installing sneeze guards, because if you have staff that are going to interact with patients and they're very close to one another, just like you see at most grocery stores, this may be something you have to think about depending on how much traffic you have in your clinic. Okay. In your office space, you have to have a plan and protocols for surface decontamination. So you need to look at your setting again first. And if your setting has a lot of furnishings with cloth coverings, you need to think about that cloth is a soft surface. It's porous. And there are just crevices in a soft surface where the virus can't be scrubbed out. And so you want to minimize those kind of things as much as you possibly can. The other issue is that now non-essential objects need to be removed, including decorative items and toys and magazines. You want to place your clean laundry in a cabinet or sealed storage container. So if you have a clinic setting where your clean laundry is on an open shelf, you need to think about that. Maybe that's not such a good idea because you can't protect that clean laundry from potential of contamination while people are in and out of that room. And then the thing that we really want to encourage you about, and then I see when we do these presentations, all of a sudden practitioners make these wonderful checklists and they put them on drives where the documents can be widely shared with one another. But you really need to create a checklist for cleaning all the items in a treatment room and in your facility. Okay, you need to decontaminate all the hard surfaces. So that means desks, treatment tables, doors, faucets, sinks, windowsills, blinds. You need to think about all those surfaces and how often you need to clean them. And you need to clean them with a disinfectant. In the United States, the requirement is an EPA registered disinfectant for coronavirus, according to the label. And this is here's the link where you can find those. But if you just search for EPA N, the letter N list, you'll get that list of disinfectants. So one of the things I want to point out about disinfectants is that in order to kill the virus, the surface has to remain wet for the entire time specified on the label for the particular product, and they go anywhere from 1 minute of contact time to 10 minutes of contact time. So you want to look on that label for the thing that specifies contact time or dwell time in order to kill the virus. A lot of antibacterial wipes won't give you that contact time. And so when you're looking for disinfectants, you're really looking for a disinfectant that can stay on a surface, usually a sprayed disinfectant. There's some fascinating new disinfectants. I think is it hypochlorous acid that can be made in electrolyzed water that is now coming on the EPA list for being effective against coronavirus. And so there is some innovation in this area without having to use toxic chemicals. They're hard to find, though. So you need to establish a frequency for cleaning according to how often the surface is contacted, and it will change depending on where you are in your clinic. So obviously the treatment room is going to be high contact. Sometimes your office space with your keyboards is also high contact. Doorknobs are high contact. Elevator buttons getting into your office might be a high contact surface. And so you have to sort of look at your setting and make a determination about all the things that you need to clean more frequently. So the high contact surfaces, the patient table, any surface touched by the patient, including armchairs, desk, counter, doorknobs, checkout counters, sinks, handles of hand sanitizers. This is something that almost everybody touches and we don't really think about, but that hand sanitizer is not going back on the handle. So you want to think about things that we're all frequently touching as we try to keep ourselves clean. That might have to be cleaned. Those surfaces should be cleaned after each patient. And then all surfaces in a treatment room, including a floor, should be cleaned daily. And then all frequently touched surfaces by staff should be daily. And then everything else, at least weekly, or look for your local guidances about how often. Laundry. So in terms of laundry, nothing can be used for multiple patients, and that includes table liners and pads that we all love and give our patients a lot of comfort, but they're made out of a porous surface. And if you put a sheet on top of it, you are not necessarily protecting a patient, and that porous surface, you can't clean it and you can't disinfect it. And so you really have to think about it. Blankets, sheets, gowns, pillowcases, they're all single use from probably should be, but definitely from here on out. We got an early question about, well, if I have a community acupuncture clinic and I have chairs and they're 6 feet apart, would I be putting myself ahead if we hang cloth room dividers? And you can actually search for microfiber antibacterial cloth room dividers, but not very many of these dividers have been tested in terms of the coronavirus pandemic. And when they were tested for bacteria, we found you'll see a lot of literature that within 2 weeks, they're actually contaminated. So the best advice is, this looks like an option for you in your clinic setting to stop the spread of the virus from one patient to another. You need to look at the manufacturer label and make sure that they're advising you for use during this pandemic. Okay, so once you put all this information together, you create a checklist for cleaning, what you need to clean after each patient. And you can create a checklist for daily and weekly cleaning. My suggestion is that you think about these as separate documents, and that they have a utility actually as a document. And I keep thinking in my head about a piece of paper, and I'm not sure that that's really the best way to do them. But what you want to do with the checklist is to create a grid where you have spaces to initial and record dates that you did the cleaning. So that really does mean every time you're in the treatment room and a patient walks out the door, you're either keeping your gloves on that you had on, or you're going to don a pair of cleaning gloves, because you can use cleaning gloves, and you're going to take care of the laundry, and you're going to clean and disinfect that space. And after that is done, you doff your gloves and you wash your hands. You're going to record on that checklist with your initials, the date, even a time that was completed, and you keep all those checklists. You file them away, because this is really your best protection, that you did everything you can possibly do to prevent the spread of the virus within your facility. So here's just an example, and this was a pretty quick one. People are coming up with a lot better ones. Oops, sorry. You can hardly read it in that period of time. So you just have a grid and you make the initials, and you can keep the checklist close to the area that you're doing the cleaning. So if it's in a treatment room, sort of taping it on the back of a cabinet space so that it's not really getting contaminated all the time by people walking in and out, but that it's handy and you can just put your initials on it and go about your business in the day. And some things to take note of is that we're going to talk about laundry a little bit later, but you should be using gloves when you handle laundry, and you should scoop up your laundry so that you're folding the contact surfaces to the inside. And then you're putting the laundry immediately into a hamper, and the hamper can be lined, but the hamper also should have a lid, and then you have to disinfect that lid, like in between every patient visit, every time. I think that is the detail about the process that we want to talk about in terms of the CNT advisory, and I'm going to hand it over to my colleague Steve to talk more in depth about PPE.
Valerie, stay on for a sec. There's just a few hand raises. So before Steve goes on, let's just, we'll go to Laura first. And if the question is going to be answered, Steve, that you know it's going to come up, then just let them know we're going to cover that. So let's unmute Laura first. And you should have mic rates, Laura. What's your question, please?
Hi, I'm just wondering about shoes. I was thinking about having patients remove their shoes when they walk in the door and put them on a shoe rack, but I'm not sure about the transmission of shoes. And then when people take shoes off, there's a whole complicating factor of walking on the floor barefoot. And some elderly patients really can't walk without their shoes from even just the entranceway to the treatment room.
It's really good thinking to think in that way about how do you prevent contamination from the outside to the inside of your clinic. Unfortunately, having shoes off where you have needles would be against OSHA regulations. And so people really do need to be wearing footwear in your clinic. And I actually have looked at information about, are people being contaminated by their shoes? And there isn't some definitive evidence that is really a big route of infection. I think the issue for the practitioner to think about, and this is just off the top of my head, there's no guidance about this that I can find in the literature so far, is that you're in a clinic around the public all day long, and it may be a good practice for you to have a pair of clinic shoes that you keep at your clinic site. And that when you come in the morning, you put your street shoes in a bag and or a container that is away from the air of your clinic, and then you put on your clinic shoes, and then you wash your hands.
Great. Next, we'll bring up Cindy's question.
Yeah, I was just wondering, in terms of the screening, I was thinking it'd be great to have like a screening questionnaire and an intake done on the phone the night before the person's appointment. Is that, and then tell them they need to let me know immediately before their appointment if any of the screening questions answers have changed. And then when they come into my clinic, take their temperature. Is that too far in advance?
We will cover that in the next section, Cindy, when we get into a little bit more of the screening procedures. And if for some reason we don't answer that fully for you, we can kind of go over that again.
Thank you. All right, let's do one more question. Then we're going to let Steve chat, and then we'll keep raising your hands, guys, because the whole idea of giving our speakers today more time is so you guys can really get clarification, ask your questions. So let's go to Diane, and then we have a few more with our hands up. After Diane, we'll go to Steve, and then after Steve's done, you guys can just keep getting clarification, asking your questions. That's what we're doing here today. Diane, you should have your microphone on.
Okay. I'm thinking I might want my clients to shower or bathe before they come to the clinic. And is there a time frame, like at least 12 hours before they come? Is that overdoing it, or? That's my question.
Well, it's good thinking too. The thing is about this virus is that between their shower and your facility, who knows where they've been. And so there's no data to suggest that would be helpful. There's no data to suggest that wouldn't be helpful. So I think that's kind of a judgment call. The thing that I would say about it is that even if you ask them to do that, you still have to do all the protocols you have to do, because you have to assume that they picked up something in the parking lot. And so it may feel like it's giving you and maybe even them peace of mind. I mean, it's nice to have skin just clean for doing acupuncture anyway. But you still would have to do all the same things.
One of the approaches you can take with that is think about educating your patients, whether it's, sending out a video that you did or an email that goes to that. Because, for example, people forget that they go to the grocery store, they may be wearing a mask in the grocery store, but they go in and they're touching all these different products they're putting in, and then they immediately take their mask off and touch their steering wheel. And then how many of them are actually disinfecting or using a wipe or something on their steering wheel? They go home, they unload their groceries, they go back in and they touch those steering wheels again. So, you can include something like showering and bathing or whatever in that kind of educational approach and send that out to all of your patients before they come to your office. And then it just gives them a general guideline of what they can do to better take their own health into their hands.
What a great answer. And actually, as you were saying that, Steve, I imagine this army of acupuncturists who are now producing information for patients just on how you deal with a face mask. Because I don't know about in your location, but good golly, I can't get portable hand sanitizer to save my life. And if I go out and I put on a face mask, if I want to take that face mask off, I need to be able to wash my hands before I touch the face mask. And there isn't a lot of opportunity to do that. So one of the ways that we need that you could really help people is to be able to just have a fun, creative, here's from your acupuncturist. I'm the expert on infection disease control in my setting. And here's what I want to know. I want you to know about keeping yourself safe while you're using a face mask. I think that could be a huge service to your patients.
So thank you. Steve's going to continue on. And I just want to acknowledge that this can be quite overwhelming. I know the first time when we started looking through all this material, I only had a little tiny breakdown, but a breakdown. It was quite overwhelming. I've been through this quite a few times, and it's getting to the point like, okay, I can do this. And then there's like, it gets to the point for me that, look, if I'm going to touch something and then I'm going to die, I'm just not coming out of my house, right? If that's the case. So just to put things into perspective, they're giving us procedures and policies to reduce the risk of spreading it. And they already know that this is not perfect. So you cannot stop the spread. We're just reducing the risk. And so every scenario is different for every clinic, every state, and every day they're going to change the rules as they learn. We were told don't wear a mask. Then we're told to wear a mask. Then we're told not to wear a mask. And now we're told again to wear a mask. So it changes all the time. So I just want, if you're feeling overwhelmed, great. You're in great company. Most of us are. Sorry, this isn't a Feel Good Friday webinar, but it's important information that we want you to have. And I just want to let you know, if you're feeling overwhelmed, please go over this again, and you'll start to see, oh, I can do this. You really will, because we have noticed that in the last week of going through this material through different people daily, we're like, okay, we got this. So if you're feeling overwhelmed, deep breaths, because I know it can be. Steve, when you go through this, because some of the questions are going to come up, and I know you're going to talk about it, but just to put it into your consciousness here, there are going to be questions about, well, how do I take pulse, or do I stop taking pulse because I got gloves on? How do I look at tongue? What's the safety rule if I want to look at a tongue because the patient's wearing a mask? What about a patient face down with a mask? Because I know you guys have been doing this, so just some of the practicality, and some people have this idea, patients won't be face down with masks, but then I know there's people already treating patients face down with masks. So if you can just kind of keep that in mind, because I know that's on a lot of people's minds, that this is how I've done it, and now you have to do it differently. And that's the most stressful part for me, and I think a lot of people, is it is different from before. And so that's the adaptability that we're going to need, so we're not stagnated and stressed out. We can't do it like we did it. That's not allowed anymore. And so there is a change that's happening. If you can just kind of give us some reassurance and some of the practicality, because pulse and tongue taking and face down, for example. And then you guys keep raising your hands. You got great questions. We'll pepper Steve and Valerie at the end of this talk. So Steve, please take it away.
All right, thank you. And again, just to reiterate, yes, it can be truly overwhelming. The key thing is we got to try to keep things in perspective and realize that this is about minimizing risk. Risk to us, risk to our patients. We don't want to kind of go down that rabbit hole and start to live in fear that I've got to disinfect every surface that I touch. This is really about minimizing the risk, and that's what we always want to try to keep in mind. So as we go through this next section of PPE, as well as we're going to talk a little bit about some of the things that Lauren had brought up about how we're going to treat patients and scheduling and how we do tongue and pulse and all those components, we always want to realize that things can be very different for you. You do what's the best practice for you and what you are most comfortable with. And we always want to go back to that we're protecting and taking care of ourselves and our patients. So with that said, when we look at our protective equipment, currently eye protection is not required unless you are seeing infected COVID-19 patients. Now, that doesn't mean you can't wear eye protection. If you feel much more comfortable with that, for example, when you are looking at someone's tongue and you're asking them to remove that mask or to look at their tongue, you want to either direct yourself slightly away from that and not looking direct on, because that is an opportunity that could allow for spread. And you've got to be comfortable with what you feel with that. Eye protection may be warranted at that point. But understand that eye protection now is not required unless you are working with COVID patients. Same thing will apply to isolation gowns. Those are not necessary unless you are working with COVID patients. And we'll talk a little bit more as we get with face masks and gloves. But from this slide, one of the things I want you to realize is that our clinical apparel becomes important. We've talked a little bit about shoes, having separate ones, but you have to remember that you have surfaces that can contain that. Watches, rings, things like that. If you're a person that wears a lot of bracelets and things that might be in close contact with that, those are surfaces that are going to need to be decontaminated as well, or washed and cleaned. So you want to make sure that you're minimizing what needs to be done. So remove those kind of things that you don't need, at least during this time, or make sure that they are covered during your examination times. Now, as far as what's required for us as healthcare practitioners, we want to look at the face masks and we want to look at gloves. So first and foremost, what has come out is that cloth masks are only allowed for patients. So patients can wear a cloth mask. It's going to protect that movement of the droplets, but it's not necessary for them to wear surgical masks or N95 or the KN95. Patients can be using handmade, purchased cloth masks. As a healthcare provider, it is required for you to wear surgical masks. So for those of you who may not be familiar with them, surgical masks are going to be your pleated style that are there, and we'll talk a little bit about this in a minute. But that's the one that you see on your left-hand side on the screen, and we'll talk a little bit about how to put those on and off. The N95 masks, which currently a lot of people tried to get, are reserved for those healthcare providers working with COVID-19. One of the things to understand, and we're going to talk a little bit about the difference between the N95 and the KN95 next, but when you look at how these are fitted, this is what becomes important. If you haven't worked in a hospital setting, the N95 mask is fitted specifically for you. It is designed to seal the face. So when you go through a fit test, you're asked, a question of, can you taste? And that taste tells whether or not there is a leak in that mask or not. And that's an important factor. So us as other healthcare providers, that risk is lower because we're not necessarily working with the COVID patients unless they're asymptomatic. So the surgical mask is adequate. If you're not familiar with the surgical masks, they do have a top and bottom. The top piece will always have a little wiring in it. That's to help create a better seal on the top of the nose. The area that you want to be most concerned with touching is going to be the inside of that mask. Because remember, these masks are helping to protect what we're putting out there, those droplets that are coming from us. So this is the surface area that you want to avoid touching. The outside is not as high of a risk. With that said, the key areas you want to use are going to be the elastic strings that will allow you to place that on, minimizing the touch to that. So of course, the hand washing process is going to be a key factor. Before you don the mask, you want to make sure hands are washed, they're clean. Place that on top. One goes over the ear, one goes over the other. The nose is then pinched to create that seal over the top, and then it's under the chin. From that point, you're going to turn around and you would wash the hands again to prevent anything, glove up at that point. Once you're done with that, you want to use removal by the ear straps rather than touching the mask itself. We'll talk a little bit about whether these masks can be reused, for how long, and when we want to kind of replace them here in a moment. So again, for us as healthcare providers, surgical masks are what we want to wear, not cloth masks. N95 should be reserved for those that are treating COVID patients or working with that. I personally had N95 masks in my office and donated those to local hospital for the use there. Still, surgical masks can be utilized for us. With that said, a lot of what we see available from our suppliers are the KN95. Now, the KN95 masks are the Asian version of the N95 mask. So they come from overseas. Most of the research, the World Health Organization claims that they are adequate or the same as N95. But what happens is they're not properly fitted for people. So again, an N95, you go through a fit test. It's a mask specific to your fit, to your face. When research was done, 3M did the research. There has been, I think, no other outside independent body that has done this test, but they looked at all of the different masks similar to the N95 and found that the KN95 has close to 8% leakage. So if you're not working with COVID patients, that's not necessarily something you would have to worry about. So then a KN95 mask is fine for you to wear in your office rather than the surgical masks. But if you are working with COVID patients, that leakage could mean exposure, okay? So most of what we've seen in the field, most of your providers feel that that doesn't create a good enough seal for the KN95. So my suggestion would be, if you're treating just as you would with surgical masks, the KN95 is fine for you. If you are working with a population that has exposure, the N95 mask should be the one that you're utilizing. So hopefully that will kind of reiterate a little bit of the questions that people have around masks.
I want to do a quick summary of that. So the ones from China, the KN95, they would be better than a surgical mask in an acupuncture clinic setting. You can wear either.
You could wear either. They would be adequate if you're using a surgical mask, or the KN95 would be fine.
But the 95 is if you're treating COVID patients. The surgical mask, the cloth mask, and the KN95 mask would not be appropriate for treating COVID on the front lines, only in N95.
Correct.
And you're wearing a KN95 mask. Will we get stoned because people think we're wearing 95s that should be for the front line?
No, they have similar, but they are a little bit different in their appearance. You know, and I think, you know, we talked a little bit before, the whole mask thing is very different for a lot of people. You know, it's still hard for me to walk around and see people wearing a mask and not be able to tell they can smile, you know, and it's hard for us to get used to that process. But you shouldn't, hopefully you don't get stoned for wearing a KN95. Now, when we talk about a little bit about how and when we want to dispose of these, ultimately in the ideal world would be using one surgical mask per patient and discard that. But unfortunately, as we know, resources are very, very tight and they're not always available. So currently, for example, even here in a hospital setting, surgical masks and N95 are being reused for up to 7 days, providing that they remain clean and dry, they don't have any defects to them, and people are utilizing proper donning and doffing of their masks. We also have 3 stations and companies that have come in and do a disinfecting of the N95 masks and sterilize them and return them. So that is one process of recycling and reusing that. Colorado has gone to that here. We have 3 facilities available because it's been so difficult to get a hold of the number of masks that are needed. So with that said, we'll talk a little bit at the end about resources, but you know, when you find these, you know, get what you can, but we're also don't want to get in the habit of hoarding things like that. We want to make sure that they're available to all of us as practitioners. There are plenty of YouTube videos out there that are available to walk you through that process of donning and doffing your mask, taking them on and off. But remember that always keep in your mind, whenever you've touched or potentially been exposed to what could be a contaminated surface, we're washing or sanitizing the hands. We want to keep that practice there. Now, as far as gloves, I know that gloves can be very different for a lot of acupuncturists. You know, being from a background of working in healthcare facilities, I'm not foreign to wearing gloves. So it's important to understand that during this time, one of the reasons that we're wearing gloves more often is because this is a droplet-based type of transmission. So there's more likelihood that we can pick up those droplets from a contaminated surface and pass that on, whether that's passing that on to family members when we come home or to other patients or to surfaces. So that's the reason why gloves are such an important factor in this process. We're so used to not having to wear them, and this is going to have to be, you know, your choice within your clinic. Gloves are going to become something that may be, you know, resource dependent. I know it's difficult to find a lot of the nitrile gloves at this point, because of the use of when we go in with a patient, we have to have them on. We put the needles in, we do all that we do, we leave the room, we have to remove that set of gloves, we do our charting, we do whatever in between, we have to put on a new set of gloves and then go see that patient again. So hand washing again, whenever we are removing gloves, placing new gloves on, as well as in between each and every patient. And as Valerie had spoken before, gloves should be worn whenever you're working with your patient's laundry. I think I saw a quick thing about the laundry, as far as Valerie went through as to how to pick that laundry up and place that in. One of the things we do is have a sealable tub that is marked for dirty linens. That's placed in there. Once that's done, then you can remove the gloves from that point. Gloves should also be worn when you are cleaning or disinfecting treatment rooms after patient care, as well as any daily treatment or cleaning and disinfection. Clinical lab coats are adequate. I mentioned before, isolation gowns are not needed in our situation. They are reserved for treating COVID patients. So a clinical coat is perfectly fine to wear, as well as scrubs can be used. If you are going to wear street clothes or semi-professional clothes, make sure that you wear a lab coat. That just helps protect you a little bit more. If you do have an instance of exposure, have a change of clothes that is available to you. I know that this is a big area. We have massage therapists and chiropractors in our office, and the massage therapists bring multiple changes of clothes because of contact, body, and movement, and having to do stretching and so forth with their patients. There's a greater risk of them contacting surfaces that may have exposure. So they're bringing in multiple changes of clothes there as well. As far as laundering, for you daily, one of the processes you can think about is, when you come home from your office, remove those clothes, do the same thing, have a specific hamper or a bag that they go into, and then go into your house, shower, bathe, and limit that exposure both at home and in the office. We want to remember, and Valerie brought this up at the very, very beginning, that, we want to take that mindset of universal precautions, that everybody could be a carrier of this, but we don't want to get in fear of it. We want to make sure that we keep clarity as far as our procedures and processes that we're working through, and doing everything that we can to protect ourselves as well as to protect our patients. So when we start to look at how we want to open the office, we want to always keep that in mind. We want to make sure that we've had that safety meeting, whether it's with ourselves or our staff. We've cleaned the facility and prepared it. And then the next question, when it comes to PPE, we want to know, do we have enough that we can provide for ourselves and our staff? And then how long can we continue that process? So if we only have one box and we're only able to stay open for a week based off of the patient load, do we really want to open at that point? Because if we don't have the protective equipment, we end up having to close down again. So the idea is to really make sure that you are prepared before you do open those doors. A question that comes up a lot is, do I provide masks for all of my patients? Remember that these are difficult to get. So one of the things to think about is, if you are, and we'll talk a little bit, I think that what Cindy had asked before about pre-screening, part of that pre-screening is going to be having your patient wear a mask and bring that with them. So you're going to have to be prepared what you are personally going to do if that patient shows up and doesn't have a mask. Are you going to provide them with one, or are you going to turn them away from treatment? And that's a professional judgment that you would have to make. But remember that these are difficult to get a hold of. So we want to minimize that. And part of that is going to be educating those patients. Wear your own masks, bring it with you. And if you have to educate them on how to do it, do a video and send it to them. Perfect way to do it. The next thing is, how is your access to hand sanitizing or hand washing? And Lauren had brought this up, earlier. Some people have, a storefront. You can come right in, you can set up a station there, or they may come in from a different entrance to the building. But the idea is that you want them to wash and sanitize their hands before they enter your space. This helps to minimize that risk. The other thing to think about is, now when they're exiting, do you have a means that is a contactless form of payment? So can they run their credit cards beforehand? Can that be done over the phone so that there's no exchange that has to happen that also increases chance of risk for exposures? As we move into pre-screening protocols, it's good to think about this starting 24 hours beforehand. So I think this is one of the questions that came up, I think, from Cindy before. Can I start this pre-screening process before? And yes, you should. This should be either a phone call that's made or an email that has confirmation that comes back. The two main questions that you want to ask is, are you experiencing any fever and any respiratory issues? Those respiratory issues include shortness of breath, a cough, or any difficulty in breathing. All of the other things that we've heard aren't necessary to be asked in the initial screening, but you do want to keep them as a secondary thought. And those questions are going to be around, have they had any chills, any muscular pain, any headaches, any sore throat? Loss of smell or taste are also important. There were some times where GI was a consideration, but it's been found to be minimal in most of the COVID patients, so it's not necessary to ask. But what you want to ask, again, is fever and respiratory issues. Now, with that said, we know that people have coughs. People have had coughs for a while. So if they say that they have a cough, how long has that cough been? If it's a chronic condition that's been longer than 3 to 6 months, you use your professional judgment. As long as you're wearing PPE, they're covered. That's one of the questions you have to ask yourself. There's also different medications. Lisinopril has a side effect of a cough. Any of the ACE inhibitors do. So it's important to understand that and know your patient and take care of this at the beginning, that 24-hour period before they come into your space. Now, the screening then is going to change on your day of service. Again, the first question you want to ask, has there been any change since the pre-screen? Then this is where you're going to take the temperature. Now, we have a lot of options out there. Some people prefer to use contactless. Sometimes they're accurate, sometimes they're not. You need to make sure that those are calibrated and they are checked. If you are using one, the scanners that just go to the forehead or temple, those will need to be disinfected after each use. The number that we look for is anything greater than 100.4. This patient should be sent home and given some instructions as far as isolation for the next 10 to 14 days, or to contact their primary healthcare provider, depending on where you're at. From there, they need to wash and sanitize their hands before they enter the clinic. And then they should be directed directly to their exam room or the treatment room and avoid using your waiting room if at all possible. We talked a little bit about furniture, cloth fabrics. We don't know the full exposure list of that, and they're not necessarily easily to be cleaned. So either covers have to be provided on that, or you would have to make sure that you have vinyl or leather material in your waiting area or places that people will sit. And then I said before, the question to ask is, what do you do professionally if this patient shows up without a mask? Are you going to provide that, or what are you going to plan on doing with that? And that will depend, I think, a little bit on your resources that you have available in your clinic as well. Then as far as treatments go, again, to minimize risk, we want to stagger appointments as best as possible. So whatever that means in your clinic, how you have to do it by hour, by 90 minutes, whatever it may be, but you want to at least also allow for a minimum of 30 minutes between your appointments to disinfect your exam room or your treatment room. Like Valerie had mentioned before, if you're not using something like Cavicide, which has a 3-minute well time, if you're using 70% isopropanol, that usually I think is a 5 to 8 minute well time. Your bleach solutions are a 10-minute well time. So you've got to keep that in mind, that you're keeping those surfaces wet to destroy this virus or reduce the risk. So that has to be built into your appointment times as well. One suggestion, a lot of areas are being instructed to go at 50% or limited capacity. So if you do have a clinic where you run multiple treatment rooms, it's a good thing to think about maybe only running one. So that allows you the time to disinfect and take care of that in between, rather than risking, one patient goes into this room, that's done, they go into the next, then you go back and clean this and back and forth. Limit your chances of missing any time for disinfection. So it's easier to run and clean one room over the other. Then the last thing when we look at treatments, and this is what Lauren had brought up before, is positioning of your patient. And what do we do if patients have to remove their masks, or when we're doing tongue and pulse when it comes to that. When it comes to doing what we do with pulse, that's up to you as far as that exposure. If you are going to have gloves on or not, I use gloves. I take pulse with it. I don't have any problem sensing and feeling pulse even through gloves. It's possibly because I've done it for a long period of time. But don't get in your head that gloves are going to restrict and stop what you can feel and sense. You've been trained, you know how to do it, you do it well. Don't be afraid that that barrier is going to change that. As far as when we look at tongue, again, maximize your levels of protection. If it means wearing eye protection while you're looking at the tongue, do so. But minimize that time that a patient has to be out of their mask. There are going to be some patients that aren't comfortable with that and are going to want to take that off. And that's just something that we're going to have to be aware of to clean and protect and make sure we're wearing that. Droplet protocol is that anytime you're within 3 feet of the patient, you should be wearing gloves and a mask. Face shields aren't necessary, but at least a minimum, again, of the surgical masks and gloves. Now, as far as patient positioning, this is, again, going to be something that would be as far as comfort level. We do know that a lot of times lying face down with COVID patients eases and takes that pressure off the lungs and allows them to take a deep breath. But please remember that your patient is going to be sitting with a mask on for the length of time that you're providing treatment. And if that mask comes off, or if they're not wearing that mask, then we've got to look at other disinfection process, face cradle. You're going to have to look at the floor space that's below that, and all of that time that's going to be taken with it. So a lot of it may be what is going to work for you best right now as far as positioning my patient. Is it going to be face up or side lying? Is going to be the easiest way for me to maximize what I can do as a provider and minimize that risk and exposure. We said before, as we end the treatment, we want to see and make sure that we have contactless payment if at all possible. And then we want to do our disinfectant process at the end of the day. And then this would be the time that we do our next pre-screening. We contact the patients the next day if we're doing back-to-back, and run through those questions and prepare them as best as possible coming into our office space. Now, as far as resources, we talked a little bit before with resources. We know that these supplies are limited in some cases, and a lot of it will be dependent on where you get those from. I use a lot of medical supply or dental supply places as well. Those are other options for you to be able to get. But remember that we have all these types of medical practices that are reopening. We now have salons, we have nail care places. All these places are going to be trying to get a hold of the same PPE that we are. So it's going to create those resources are going to become more and more scarce. And again, if we have the resources available, that's when we're comfortable to open. The last part that we really kind of want to talk about is that traumatic stress level. One of the things to understand about COVID-19, this is a very isolatory infectious disease. A lot of times, we complain and we say we've got cabin fever. We've been stuck for a month, some people 2 months in our homes, and it drives us crazy. But when we look at the treatment in COVID-19, it is so isolatory that when they are hospitalized, these are patients that no longer have access to friends and family. They're not able to see any of these people that they're used to, and many of them die, and the last people that they see are those healthcare providers that are caring for them. So it is very isolatory when it comes to care. It's also very isolatory for those providers that are caring for them, as well as those people that are at home. So with that, we see that development of traumatic stress or that development of fear. And we're in a perfect position, as providers to help with that process of transforming fear into something that's more calm and clear and more creative in nature. But what I want to really reiterate is to remember that we as providers are, susceptible to secondary traumatic stress. And that can come from just witnessing. That can come from hearing what the media has to say, can create that level within our body. So we want to make sure that we have our own self-care practices, or those types of self-care practices that we can teach our patients or our patient's family to be able to help work with the other side of this disease, not the physical and physiological components of it, but the mental and emotional aspects that coincide with being isolated or being quarantined or working with patients over and over again that have exposed to that. So whatever your self-care practices are, utilize them, or share them with friends, share them with colleagues, so that we can help kind of spread that part of this through that traumatic stress process. Now, when it comes to referrals in the end, what we see in the clinic, every place is going to be different for people. Here in most of the states, if a person comes in and has, signs and symptoms of that, they are referred to a Western provider. Tests are still scarce and difficult to get a hold of. And in some cases, it's not necessarily the test, but it's like the swabs and the things are in short supply, so they haven't been able to conduct the tests. So here, for example, in Colorado, tests are currently only being given to those who are symptomatic and require hospitalization, as well as those healthcare providers that are treating or been potentially exposed. So the self-quarantining of 14 days is what we want to look for. And that's why we mentioned that before. Patient comes in and has that 100.4, but they have no other symptoms. That's that self-quarantine. And we want to document that. So if you saw a patient and you turn them away because of that fever or that symptom, that gets documented in their chart. And then you got to make sure that you disinfect and go from there. And then I think the last slide, Valerie, you want to unmute yourself? I know that this was, I think, the link that you had for the CNT advisory.
Yeah, this is the long link to it. I think this is being recorded so people can have access to it later if they miss this long link. But you can search for it also at ccdaom.org. And that advisory is footnoted so that it takes you to a lot of the studies that the recommendations were based on. And I think that is almost the end. I think you're driving, Steve, so there we go.
All right, so we'll get rid of that. So we're going to go to Q&A. So guys, raise your hands if you have questions, and we're going to have this go to our presenters. Thank you very much, Steve and Valerie. Such incredible information. Just to let you guys know, when you want to come back and review this, if you go to the page that says healthyseminars.com/resources, scroll down to either the COVID section or go here. And right now it's still the Zoom link, but if you're watching this as a recording, and by tomorrow, you'll be able to find that the recording to this through that link. So you can just go to the calendar and go to May 8th, or you can go up here and you'll see that we have other topics on the COVID-19. So we're going to go to the hand raising. I do know that some people are still stressed out, and I know I'm saying this, it's kind of jokingly, but kind of serious. I have a website called with Conscious Talk Interviews. It's laurenbrown.com. There's some wonderful talks there, and I think it may help you breathe and feel calm. And check out my introductory talk just to kind of give you a shift there. You guys can do this. It is new. It seems overwhelming, and I hope the point was emphasized that they're setting up policies and procedures to reduce risk. And like there's a question, if you have a bathroom in your clinic, do you close it? Well, unless you want to clean it every time, yeah, you use it and close it to your patients. There's a potential. Like these are things that you're going to have to decide on your own as you get more and more information on a daily basis. And some of you may say, you know what, forget it. I'm just not going to open until COVID is gone. So this is information to help you get your practice going so you can do it safely to protect yourselves and others. So let's go to the hand raising.
Before we start, Lauren, let me interject one quick thing. I know that I saw come up a few times was like, for example, use of the pulse oximeters and things like that. When it comes to our practices, I know that not everybody does vital signs. It's an important part of my practice. The pulse oximeter is one that I do use when taking vital signs. Temperature is one that I'm always doing. So the pulse oximeter, I know, has been seen in some cases as beneficial. It's not necessarily as accurate. And you also have to understand where you live. So for example, where I'm at a higher altitude, we look for someone that has at least a 95%, whereas when I had practice in Florida, 92% was considered to be adequate. So you need to realize where you're at as far as that goes. But the key factors, again, when it comes to vital signs are going to be that temperature component. It's just kind of in the forefront of being one of the top things to look at, but also looking from a pulse oximeter standpoint, it isn't a bad idea. It can be done, but it's another piece of equipment that then needs to be disinfected after use from your patient when you're screening.
All right, let's go to the hands. So Sandra, if you can do the unmuting, and let's open up Kathleen, give her mic rights. You should go, Kathleen.
Hey, thank you both so much. I see a lot of people are saying thank yous in the chat, and I certainly want to. This is so helpful for all of us. I have a few questions, and a lot of these I've seen in the chat, so I know a lot of us have these. One is regarding removing all the decorations. I'm wondering, magazines seem obvious, but if it's something that's sitting on the shelf that's just a pretty thing that warms up the room, I'm wondering why that would have to be removed if you don't think it's going to get touched. And then also wall hangings. Do wall hangings need to come off too?
That's such a good question. And what you need to think about the decorative items is that if it stays there, you have to have a plan for cleaning it regularly. And theoretically, same thing for wall hangings. Oh gosh, I know that seems really daunting, but in OSHA regulations for just cleaning treatment spaces, they do talk about regular monitoring of walls and floors. And you want to think about that this is an airborne infectious virus. It's different than the protections that we're used to that are much more about body fluids. So I think you'll have to think about that one.
How would a wall hanging be different than the wall itself? It seems like they both are going to get equal exposure, right? Or is the wall hanging for some reason get more?
They could, and this is such a good question because there's actually a lot of debate out there about, well, what about curtains, like hospital curtains, and what about walls? And prior to COVID-19, the recommendations in a facility that was taking care of patients are that you clean things that are visibly soiled. But how are you going to know about this virus? The thing about a wall hanging is that it sounds like a wall hanging is going to have soft surfaces. It's going to have a lot of crevices that can sort of gain a little contamination. If nobody's touching that wall hanging, how are they going to come in contact with that particular thing? So I think you have to think that one through. Maybe it's not a big deal, and maybe it isn't. I want to say something before we run out of time because all these questions are good. I'm watching the chat, and there's such good questions. I'm so glad to see it. When I have a question like this, what I do is I end up going to the CDC site, or I try to find some literature where somebody has actually studied this. So what about wall hangings in hospitals? What are they saying about contamination about it? And then I look at the evidence and then make my decision. There was something that came up a couple of times. We had a lovely little chat in there about toilets, open or closed. And that is an active conversation in healthcare guidances about what you need to do about that. And so I think that referring you to the fact that there is a literature that you can access that might help inform you for your situation would be appropriate. We had a good conversation also about, do you really need to clean that handle of the pump? Because aren't they going to use the pump and then wash their hands? I honestly don't know if there's been any guidance about somebody taking a swab on pumps, but eventually they're going to do that. So you could find all that. anyway, we can't answer every question, but maybe we can give you an idea of a process that you can go through when something occurs to you and about how to find the evidence to think about it.
And one of the things to think about too, Kathleen, I mean, when it comes down to, cleaning that treatment room space, it's not something that we always think about because a lot of people are in their private practice. But for example, in the hospital, those procedures are written down. Those rooms are cleaned every night, from top to bottom and things like that. And it's not something that we necessarily always think of. And that's why we wanted to bring that up, of having that checklist of, at the end of the day, this is what you would do. And if that means, wiping down and spraying that wall and that whatever that wall hanging or what might be there, that just becomes part of that process for you. Would you need to do that necessarily with, every patient, after every patient cleaning the walls? No. And I think, we want to know that exposure, if they're not wearing a mask and they cough and they sneeze in the room, what happens then? Those are the kind of things where wall hangings and stuff like that might need to be looked at. So I think that may help a little bit.
And so we're going to go to Lauren next. And I just want to let you guys know, if the speakers are okay, we're going to go until the hour here. So another 25 minutes, because we really want to make sure these questions get answered. And I'm just going to reiterate, and Steve or Valerie jump in. Like somebody said, what happens if a patient can't wear a mask? And I just want to reiterate that everything's about risk. And so if a patient, we don't even need to know the reason. You just, again, it's not like a law, or is it a law? Like you assess it, and maybe you make that choice for that specific patient, that their treatment is so much more necessary than them not getting the treatment. And I'm assuming that some of these policies are for the safety of the patient and for your safety. And however, there are going to be cases where you're going to have to use your head to think what's in the best interest of the patient and you and your staff.
I would you have to look at those local public health guidelines because they're now coming out in a lot of areas in the States, at least. And they're very specific to certain kind of healthcare practitioners. For instance, in Washington State, if you're a massage therapist, you have to wear gloves. And so they put that out as a guideline for you. Because they have some oversight about what you do as a licensed practitioner, it's probably the highest recommendation that you actually follow those local guidelines.
Thank you. Let's go to Lauren.
Hi, thank you so much. I saw your information on Wednesday. It was nice to have a chance to digest it and see it again. A question I've been thinking about. So I have a small practice, maybe 20, and I see a lot of people weekly. I have a slightly different style of practice. And I was thinking of creating a bin per client. So if they come weekly, where I would have, let's say, maybe judo clothing for them, and then they had their mask, and then maybe what I do, and then every month, would wash that. But during that time, I'd have a transition place for them to come in with their street clothes, take that off, then in a clean place, have them change. Then they could open up their bin. Is there any reason? And then I would change scrubs between clients because I do a lot of very orthopedic work. So I'm pretty hands-on with people. So is there any reason that I can't, for like myself, I could just put in their folder and maybe put it in a paper bag or in a plastic bag and say, okay, this is my client for this, my mask for this client, and I don't use that again for a week. I change my clothes, and then they have a bin where they have their own mask. And then I'm thinking, do I want to invest in surgical masks or the KN95? Because I can't quite figure out which would be better. And so anyway, so the question is, could I create a system like that? Like if I only see 20 people a week and 50% of those I'm seeing weekly. For people I didn't see weekly, I'd come up with something else.
I think Steve is probably going to handle the mask question. In terms of having something that you store for patients that they wear, you can't store dirty laundry. And there are some guidances out there about laundry, and while you can sort of store laundry for a couple of days while you're getting it clean, the idea is that you clean it pretty quickly and then it's not sitting.
I didn't mean laundry. Well, I guess maybe they wear their outfit or their their mask, you're saying that would be considered dirty laundry?
Well, the mask is, I'm going to let Steve answer the question about the mask.
Not having the idea, I can see.
Yeah, well, the requirement for healthcare providers, for instance, is that you can wear a mask all day. And there is a lot of questions are coming up about masks and gloves and how to deal with them. And the best site to look at for some guidance about this is on the CDC site. They actually have a dedicated place for what do you do about masks when masks are scarce, and what do you do about gloves when gloves are scarce. And so it takes you through the scenarios about, okay, well, I can't get any gloves, then what? So I think that might be helpful for you. Steve, I'm going to toss the question to the mask.
Yeah, as far as the masks, it's the same idea of the dirty laundry. It's not something that you want to be responsible for storing. Your own mask is one thing. And like we mentioned before, the inner part of that is what is the most potential infection. So they can be folded over just like we did the sheets when we removed them, so that the inside is in and they can be placed in a plastic bag, and you would reuse that throughout the day. Currently, because of the scarcity, they're being reused up to 7 days, even with multiple patients, as long as there are no tears in them. They're not soiled or overly soaked. They're not wet or torn. They can be reused for up to a week. But again, ultimately, if you have the resources, they are typically exchanged after each patient. As far as whether using surgical versus KN95, it's going to be what you have available to you. As a healthcare provider, you should be wearing minimum surgical mask or KN95.
And Steve, what happens if you have, say, 2 or 3 surgical masks? How long will the virus live? So if you can rotate them, like I'm going to wear this one for today, and then it goes into a bag, and then tomorrow I'm going to wear this one for the day, and then the next day this one, and then I recycle back 3 days later to that bag number 1. Is that a strategy? Because
that's a great strategy to do. Just make sure that you label it, so that you know which is which, and you're keeping track of that. And again, before you're using that mask at that time, you want to check and make sure that it doesn't have any tears or any rips in it. It's clean and dry as far as that goes.
Thank you. All right, Serena, we're going to unmute you.
Yeah, hi, can you hear me?
You can.
Yes.
Yeah, thanks. I had a question. I had heard on another presentation that we should limit FaceTime to clients to 15 minutes and that would impact our billing practices as well, that we should only be doing 1 set of needles. Do you all have any guidance on that?
I have not seen any guidances that say you should only do 1 set of needles.
What about you limiting FaceTime with patients, though? Like, so you're not in the room for 45 minutes to an hour?
Right. So this is a recommendation as part of what you look at in your setting to kind of do social distancing. And again, it's about, is it practical and can you do it? And so Steve presented an idea where maybe you could do phone intake and then escort the person in while they're in your kind of virtual waiting room. And that just cuts down on the amount of time that they're in the facility. So that might be an option if it works for you. None of these are mandates. They're sort of ways to think about how do I minimize the amount of time that somebody is in my facility. Did that answer your question?
We'll just let them ask because we have so many. We'll just they'll raise their hand again if they need clarification. Sorry, guys. Anne-Marie, you have the mic.
Yeah, I treat patients in their homes, and I clearly cannot disinfect their homes before I get there. So what suggestions would you have for me? And there are other friends of mine who also treat patients in their homes.
Steve, you do some traveling. Do you want to?
Yeah. Again, it's going to be, you're not going to have, like you said, any control over what happens within their home. So this is where your own PPE is going to be very important. So you're going to want to make sure that you are prepared before you even go up there. You're going to need to have your own portable, sanitizer in addition to being able to use sink for washing, that they may have. But like Valerie had mentioned before, a lot of it is going toward, using hand sanitizer as a better choice. And part of that is really because people just aren't washing their hands as well as they should be. Part of the whole mechanism of breaking down the virus is the friction, as well as the soap breaking down the lipid bilayers that are there that allows that to deteriorate. So if we aren't following that procedure, then that hand sanitizing is the next best thing. So it'll be a procedure protocol that you set up, Anne, where, you're not going to necessarily show up and have, your gloves on, but the mask will need to be on when you go to that face-to-face contact. And then whatever you utilize as a hand sanitizing or hand washing procedure for you and the patient you're treating in their home, and make that part of the protocol that you're doing. But it's all about minimizing your risk at that point.
There are some good guidances for visiting nurses, and so you'll have to sort of wade through visiting nurses who are taking care of potentially ill people with COVID-19 and visiting nurses that are doing other care. But that might be a good website for you to refer to.
Cindy, let's bring up Cindy. Unmute her, please.
Hi, I have two quick questions. One, in terms of house calls, what do you think about treating patients outside, like in their backyards? And secondly, is there any concern with having a patient laying face down when you leave them alone in the room in a cloth mask of like suffocation? Not just being uncomfortable, but actually like falling asleep and not being able to breathe? Or is that ridiculous?
There's no such thing as a ridiculous question.
Exactly.
And there's no evidence that people are suffocating in masks as long as they're generally healthy people. I mean, and they're not children. And no, but I'll let Steve comment on that.
Again, treating outside, you're minimizing some risk when it comes to the aerosolization of the droplets. It helps with that, like we talked about, having windows open. That's great, but remember also temperature issues, elements, things like that, wind, all of those things can play a factor into that. And again, it's going to have to be a judgment call based off of you. But as far as, with the mask components of it, we know that also laying face down in a lot of cases, it does take that pressure off the chest wall, especially when patients may have fluid or potentiality in the lungs like that. It takes a lot of that pressure and allows them to breathe better anyway in some cases. So I wouldn't be as concerned about that. You just want to make sure that then your procedures following a face down patient for disinfection are part of your process.
Thank you. Next up, Sharon, please.
You remembered how to say my name. I'm very excited.
I like when my staff say I'm trainable. Isn't that special?
My question is about using sheets versus table paper. So if I'm taking the sheets, if I decide to use sheets, I usually launder them at home. So I understand like folding them, over together so that things aren't spread. But is it too much risk transferring that at home? And then I also think, well, I'm transferring the clothes that I'm wearing home to wash too. So I'm trying to figure out, is it best to ditch the sheets completely, or is it okay to bring them home to launder along with my own clothes?
What I can tell you is that all the guidances say that, doing the laundry, the virus is really a wimpy virus in terms of that. And that just using you don't have to use a disinfectant, just using detergent in hot water settings is acceptable. But almost every guideline says you should use a commercial dryer. And so I think that's about the temperature of the commercial dryer. I haven't seen any guidance either way about you can't do this laundry at home or you can do the laundry at home. I haven't seen that. So if that's helpful for you, there are actually guidelines out there about temperature settings, and the virus, once you deal with it properly, doesn't tend to live in laundry long.
Thank you. Next up is Kelly.
Sorry, you need to unmute. I have a couple of questions. One is, what if you're in a building where you have a shared bathroom? There are multiple businesses in the building, and so that's like a nightmare trying to keep that What's your suggestion?
I think, logistically, again, it's going to be about educating your patients with what's going to be best practices. If that's going to be, opening the front door of the office building and then going directly to your unit or your space, make that part of your education process or your pre-screening process. And then you've got to look at, are you going to be responsible for, let's say they have to access an elevator, or are you going to have to be the one that's going to go and clean those doorknobs and clean the buttons on the elevator and do all of that? So that has to be part of how you can access your space and be able to kind of control that as best you can. I would also check with what your building, your landlord, or what they're doing as far as cleaning procedures go, and make those recommendations, you as a tenant, that these types of cleaning or disinfecting processes, because I'm a medical provider here in your office space, are you following these procedures and protocols to help protect my patients and protect the other tenants?
No, you're still muted, Kelly. I'm going to anticipate a little bit of a follow-up here. There are criteria for office buildings, and they have, theoretically, they should be doing more frequent cleanings in shared spaces. I think many practitioners are going to be in integrative settings with other practitioners, and if possible, I think you need to be contacting the leasing agents and asking them what they're going to be doing to increase the cleaning so that everybody can open. And then if you're in an interdisciplinary setting, you're going to have to sit down and have that safety meeting with everybody. And if they won't do it, then you need to have the safety meeting with yourself about how you're going to be in that scenario.
Can you tell me the difference too between why we're wearing a surgical mask versus like the homemade cloth masks? Like, what is there a different level of protection there, or?
Theoretically, yes, and that's some testing. The chat went by really quickly, but I think we'll be able to provide some materials. There's a really good study out about the use of cloth and using two different kinds of cloth. And it was in a laboratory where they blew particles through it, and that's being preferred over a single cloth, same cloth layer. And that study was accessed, when I looked at it yesterday, 117,000 times. And it's a really good one. But for a healthcare provider, it's not considered tested or enough for you. However, again, on that CDC site, what if there are no face masks? Can you still work? And there is guidance about being able to use cloth masks. And you probably have seen stories about people who are working in hospitals who cannot get masks, and they are bringing cloth masks because some protection, a face mask is better than no protection. So if you're going to be using a cloth mask, I highly advise that you look at those sources for 2 layers. The thread count's important, and it was cotton and silk, cotton and chiffon, and cotton and flannel as combinations block a lot at small microns. Again, Kelly, you're muted.
Lauren, you're muted.
All right, Kelly, if you have a follow up, we'll just. I think I don't see her button.
I had one more question, which was about the contactless payment. What are you meaning about that?
For example, having credit card payments taken care of ahead of time, or payment done over the phone prior to, so that you're not having an exchange necessarily of cash or a check, or if that's the case, you want to have some type of methodology set up that their payment is placed in an envelope and they put it in, this drawer, this slot, so that it minimizes that potentiality of risk. If you're doing insurance billing, you're fine because you're going to be billing that out afterward. Or again, if they're doing credit card, take that credit card information during your pre-screening time, and then payment's done.
Good. Thank you. All right. We're going to bring up Casey next. Follow-up question on the linens. I've seen this in the chat room. If you put linen over the table and then paper over the table, after the patient throw out paper, put linen in the laundry basket, Does the table need a thorough clean since it's been covered by linen and paper? Still does. Okay, thank you. Tracy, you should have your
and
mic.
that would be pre-COVID advice, actually.
Yes.
Hi, my question is about the glove. What's the difference between just washing your hands thoroughly before and after seeing the patient versus putting on gloves every time?
This comes down to a couple of things. It's the same thing that most of us know at this point. We don't need to alcohol swab points anymore. But for example, in certain cases, it allows the patient to feel safer and a lot calmer in that regard. So a lot of times, yes, the hand washing process is a key factor that is there, but there's also that level of safety and security that is also felt by the patient, that we're doing everything necessary to provide that care and minimize the exposure to the patient. So a lot of times those gloves can just be that mental aspect for that patient as well.
It can. One of the things, the CNT committee fought really hard and actually had advisories out about the practice of acupuncture, and that because of the nature of the practice of acupuncture and the rarity of encountering bloodborne pathogens, that gloves were not necessarily required for acupuncture treatment. That said, some states mandated it. So there are plenty of acupuncturists in the States, and I don't know in the provinces or elsewhere in the world whether gloves are mandated, but plenty of acupuncturists have to wear them all the time. We fought really hard to be evidence-based about that requirement so that we were talking about the specifics of acupuncture practice. But this is not a bloodborne pathogen. This is an airborne pathogen. Yep. And it's universal, so you can't really screen whether that patient you're treating has it or doesn't have it, or whether they have it on their clothes or they don't have it on their clothes, or on their skin, or on their face. And so you have to sort of think through, what am I touching? What am I doing? If gloves are scarce, for instance, and you cannot get them, then how do you face practicing? And that means really diligent hand washing. The thing about COVID is that we really do believe there's some good indication that people have touched a surface where there are droplets, and then they've touched their face and they become infected. And so the idea about you wearing gloves is that you're going to be in close contact with a lot of places on a patient, and you'll forget and you'll touch your face. Now, you're wearing a face mask, so that will be helpful. And that's one of the reasons why you wear a face mask. But given the close proximity to your patients, the number of patients who are going to come in and out of your treatment facilities, the number of surfaces that you may touch before you touch a patient where they're going to touch that place and then they're going to touch their face, it is just one more barrier to keep the Rona away.
Thank you. Next, we're going to bring up Abigail. And if your speakers are willing to stick around, again, we'll probably go even a little bit longer, because my goal is we talk about community and information. I think the more you get to ask and hear this stuff, I'm hoping it brings down our stress and overwhelm level, and that more of you will end up going back to work to support your communities because we ease that tension. So we're going to keep going for a while. Abigail, you have mic rights.
Hi, I have two questions. Thank you. The first is about laundry again. So in my clinic, I use a laundry service and I store the laundry for 1 week in between pickup and drop off. Is there anything different that you know of that I would need to do? So the soiled laundry goes into a soil bag, which is closed up with just a drawstring, and then I store it for the week. And the second is about how I have one sink in my office and a common shared bathroom. If I want the patient to hand wash in my one sink, which is the only one that I have to use as well, do I need to clean that sink? How do I need to clean that sink in between each of those hand washings?
In terms of the laundry, I would ask your laundry service.
Okay.
They actually, laundry services are probably getting this question and researching it and getting professional guidance about what should be done. And so I would follow their guidance on that issue. And then the sink that is in your office, the faucets definitely become a high contact surface, and they should be cleaned in between each use.
Is there a way to clean that? That is Cavicide or something? I don't know if I'm going to be able to buy that. Is there a way to clean that without requiring 10 minutes between those uses?
There are disinfectants for those surfaces that do not take 10 minutes, and I'm very excited about this electrolyzed water disinfectant. If you have never heard about it, it's time to look at it, and they're hard to get, but you can make it. There are machines that make it for you out of salt and water, and this is maybe a time to take a look at that, because I think the contact time for those substances is much less.
Okay, and then if I could just ask one more question. Am I understanding what you're saying, that I'm on the second floor of a building that has an elevator, so there's an entry door as well as an elevator, and then my door, 3 points of entry, sort of. Am I understanding what you're saying, that I am liable for all of those surfaces being sterilized every time one of my patients touches them?
Oh, that's a great question. And I'm not being a lawyer, I don't know that I can answer it for you, but as a practitioner and thinking ethically, what is my duty as a practitioner, knowing that somebody has to go through that? If practical, you might escort your patient into your office, and or you might develop patient instructions about how to get into your office building. For instance, having Post-it notes in an elevator to push the buttons with is something that you could instruct people to bring with them. I have not seen any kind of guideline that you have to maintain that you're like personally responsible, but having some protocols in this day and age is probably a smart thing to do.
Yeah, make sure, just check with your leasing agent or whoever you're going through, as well as look at your lease itself. I've known practitioners that in their lease it was written that they're responsible for the time the patient walks in the main building door to their space, and then a lot of leases it's not. It's whenever they enter your space from your door forward is what your liability is. So check your lease, and then just look at what the cleaning procedures and protocols are that your office building has.
And your liability insurance might be a good place to check too.
All right, ERYT, let's unmute ERYT, please.
Hi, thanks for doing this. I have a quick question. If you have any thoughts about people who have cosmetic acupuncture as part of their main practice. We need access to the face, so they couldn't really wear a mask. I think I might personally wear a face shield, and that I'd be in more closer proximity. Any thoughts? I'd love to hear what you have to say about that.
From a protective standpoint, I think you're right on point. Eye protection, and if you can get a hold of a face shield, that's going to be the best thing to protect you in that case, because you are needing to have that exposure to the face. And then a lot of it's going to be also your body awareness, to where you're not directly on top of that exposure with the patient. Learn to position your body that's best comfortable for you, that you can still do your job without having an increased risk. Valerie, you want to add?
No, I would just say that in some locations, you may want to look at, there are some locations that are putting out criteria for acupuncturists going back to practice, and they're writing into their regulations that for a certain period of time, you should only be seeing procedures that are this undefined essential procedures, but then they go on to say like musculoskeletal pain. And in terms of doing cosmetic acupuncture, it may be in your location. If it's restricted, it's one of those procedures that you may have to think about scheduling depending on the regulations. But the very smart thinking is about having goggles and a face mask. Because you could theoretically write a protocol that this is what I'm going to do, to prevent infection, and this is how I'm going to clean the room afterwards. And that might answer any regulatory agency's questions about whether you can do that treatment. I want to mention a couple things here. One is that coincidentally, Steve and I were asked to do this presentation originally for an acupuncture association in Colorado, and their governor's office was going through how are they going to open up and who can open up, and acupuncturists really aren't that essential, and so they can't open up, and chiropractors and PTs can open up first. And we suggested that they take this presentation to the governor's office and show them what kind of training you have in being able to have infection control, and they changed the status of practitioners in the state of Colorado. So having that plan, I saw in the chat something about the Department of Health in Maryland had put out, this is a template for an infection control plan, which, by the way, is the sort of, it looked in a quick glance like the standard OSHA kind of template you should have anyway. This is really a time for our profession to shine as the certified practitioners of infection control that you are. And so I think having some written protocols around that would be really helpful. There have been a couple of comments that have gone by about, feeling overwhelmed. I spent a part of my career in the Pleistocene era a long time ago as a EMT paramedic. And one of the things about having a protocol when you need to do something in a repetitive way is that it really helps your mind get out of sort of the limbic brain and get into a different kind of thinking. And so for all of us who are somewhat traumatized about this virus, and then we have all the things that are happening in our personal lives behind it, it sounds really maybe counterintuitive, but just sitting down to make a protocol so that you know that you're going to do step 1, 2, 3, and then you accomplish step 1, 2, 3 over and over again. It moves you from this place of not being calm to all of a sudden knowing that there are steps that you are doing and that you are doing the best guidance that you have, and you really are cutting down transmission. We've seen that over and over. So this is a way to be able to enter practice and not be afraid about it.
Thank you. Next, Michael, please.
Oh, hi. Normally in my practice, I incorporate Tuina and cupping with the treatments. And I was thinking and going back to practice that I might want to put those aside for a while, but that would be kind of unfortunate because I think they're an important part of the treatments that I give. But have you guys given some thought to safer ways to incorporate those or other modalities? I think that's maybe a really big question, but I don't know if you have some kind of easy answers.
It's a good question, and here's where I would go with it is, these precautions are universal, and the same thing that we're using just for acupuncture, they're going to work for Tuina, and they're going to work for cupping. There's nothing specific about those procedures that can't be protocoled around.
Right.
So you just have to, for Tuina, now you might be doing Tuina with gloves, which sounds a little weird to me in the beginning, but if I did it over and over, I would find that my sensitivity to the field of qi is going to go through that thin layer of gloves. So I think you can write protocols to do your practice, and your patients probably would really love it.
And it's the same thing. You already follow from your practices and your knowledge of how to disinfect your cups, how to disinfect gua sha materials. That doesn't change now that it's COVID. It's the same practical and protocols that we've used before. So there's no reason why you can't continue offering those services to your patients.
Thank you. Next up, we're going to Trish, please. Trish, you should have mic rights.
Okay, hi. I have a question about scrubs. If you decide to go with scrubs, do they need to be changed in between each patient?
As far as it depends on you and what level of exposure that you have with your patient. You don't need to necessarily change in between each one. If they're starting to get soiled, they're wet, they're damp, or whatever, then you're going to want to change those. But typically, you're going to be fine wearing the same scrubs all day. It's if you have that risk of exposure, or let's say you're doing a lot of orthopedic and body work, where you might have a lot more skin and exposure that is done onto your clothing, then you might want to change those clothes.
All right, Pauline, you should have your mic right.
Thank you. Okay, so thank you so much for doing this. It's really helping. First question I have is about carpeted treatment clinics. I rent from a clinic that rents from someone who rents from someone else, so I don't have a lot of control over the environment. Just wondering, I'm kind of imagining the person coming in, and then if they have to wear shoes, we used to have these Crocs, but most people didn't want to wear common Crocs, even if I'm going to say I'm going to spray them. I don't know if that's better if they change or if they wear their own street shoes into the room. And then it's carpet. So any suggestions on that?
What's the question around? And because we're way over time, and so we're going to have people do one question. So ask your most important question. Pauline, can you just rephrase that? What's the question regarding carpet so they can kind of give you a specific answer?
What's the best way to deal with that situation to minimize the pathogens that might be trapped in the carpet?
It's impossible to think that a lot of us don't have carpet. A lot of us do. Carpet is a soft surface, and the best I could find is that certainly before opening, you may want to think about good steam cleaning on that carpet, and then get some advice from steam cleaning companies. How often are they steam cleaning carpets? There's nothing about shoes that are going to make your carpets dirtier than somebody coughing on the carpet, and it just is that it's a soft surface. And you just have to keep it as clean as possible. Your patients are probably not going to be sitting or lying on the floor on the carpet, so their contact with that surface is going to be quite removed. It really is your treatment table and the surfaces that they're going to contact that are probably at higher risk. And so there's no guidance that you have to put in bamboo floors at this time. We wouldn't ever go so far as to say if you have a carpet in your office you can't open. That's just that's not where we are.
Good to hear. That hasn't got to that. Basically, people are touching things. So people, if they have it, they have it. And as I think Steve said at the beginning, assume everybody has it, and you're just trying to wash your hands, minimize, wear your mask, and if you don't pray, now's a good time to start praying. Christoph, let's unmute Christoph.
Hi. My question is about gloves. What I want to know is, if I come in, if I have gloves on, can I use hand sanitizer on my gloves and then not have to take them off? That's the first part of the question. And the second part is, I have a bunch of gloves that I have for patients. So if the patient walks into the clinic, I meet them at the door, I test their temperature, they're okay, and then I have them put on gloves. Is that sufficient for them to, they can use those gloves and they can sanitize on top of the gloves?
I would say for a resource standpoint, keep the gloves for yourself rather than the patients, because you're going to have to disinfect afterward anyway. So don't waste the gloves on the patients having to wear them. I believe that Valerie had mentioned before, there are some procedures or processes that put in place to feel that if we are limited in the supply of gloves, there are some things that you can do to sanitize them. But the thing is that there is also greater risk that there could be a tear or a breakdown in that material that could increase risk of exposure. You've got to look at what your procedure and your protocol is as far as when you put your gloves on, see that patient. I would suggest that regardless of if you're sanitizing gloves in between, you do not use those same gloves for another patient. You would have to discard those gloves, even if you're sanitizing them after that patient is done, a new set of gloves for a new patient.
Thank you. We're going to go to Joanne and just Cindy's question there, because Steve, you mentioned, but it's worth repeating because I think it's more about perception. She's saying, I don't understand how gloves are better. You can still touch something and then touch your face. I don't get it. And you had mentioned something, part of it is either being mandated and part of it is just perception. So can you just reiterate that to people?
Some is perception, but I can tell you from just going to the grocery store with gloves on, I have gloves on, I don't touch my face.
Right. It's the same way that we're less likely to touch our face with a mask on. You're less likely to touch your face with the gloves on. It makes you think about that. Whereas if, you've got a mask on and you go and you're in the grocery store, or you're working with a patient, whatever it is, you may do something and then reach up to rub your eye. The gloves are kind of a remembrance for us as providers as well, not to do that. You're going to see that color, you're going to see those things. So it kind of is part of that remembrant factor for us to not touch. But yes, that's the biggest thing, is that the factor is that we're not looking at bloodborne pathogens. It's a droplet. So that can be touched. It can be on the glove and then go to the face.
Same thing about your patient. I've gone out of my treatment room. I don't know that I'm contagious at the time that I'm treating. I cough into my elbow. I touch my elbow. I'm itching. Theoretically, you're going to wash your hands and then put your gloves on. So you're going to have gloves, but it's another layer.
All right. Next up is Joanne.
Hi. Thank you. I was just wondering, I work in a community clinic setting, and we typically have sheets on top of the chairs, but the chairs themselves are recliners, so they're porous. So I'm just wondering what the risk level of that is.
It's a little bit of an increased risk because I'm sure it's a clean sheet on top of a chair.
Absolutely,
because it's not it's not something you can't disinfect that chair. Mm-hmm. And so I can't tell you not to use the furnishings in your clinic. I think you just have to look at, is this a vector for infection? How can I minimize that risk? And there was a question in the chat about, can acupuncture be carried out in community settings? And I have to say yes. And oh my gosh, everybody who needs acupuncture needs community clinics. You just have to think about your settings and how you can appropriately socially distance and stagger treatments so that people are not coming in close contact with one another.
Great. Thank you.
All right. So we're going to finish our last question with Kathleen, and then we're going to open our mics and give our love and appreciation to our speakers, because we are on over 2 hours and 20 minutes with this lovely co-presenter, which I'm so grateful for you volunteering your time to do this. And for my team and Sandra, who's already on Saturday, I think in Ireland, who stayed up late for this, and for you guys with your amazing questions. So we're going to give each other lots of love and gratitude, and especially our speakers. So Kathleen, you got one question, and the mic will be open for you almost now. Sandra, can you open her mic?
Yep. Okay. Thank you. Someone mentioned earlier that, and it's, we've all heard that there's a clotting issue. There are clotting issues with COVID, possibly presenting in deep muscle aches. In this case, with gua sha, tui na, cupping, are they possibly contraindicated?
What a good question. Oh, I want you to be my practitioner with that kind of thinking. That is really a good question, because if you look in the CNT manual, which was expanded to include some safety considerations for other adjunct therapies like gua sha and cupping, there is maybe a little bit of concern about people with coagulation problems. I really like this thinking. But here's the thing, is that if you're treating people who are asymptomatic, they might be spreading the virus. They could get sick in 4 or 5 days. Even if I hear myself say it and I'm thinking about those bruises, there is a problem. Mm-hmm. I don't know. It's something to think about. Haven't seen any evidence on it at all.
I haven't either. So that's a great question.
But oh my gosh, Kathleen, are you ever taking care of your patients?
Great. All right, so we're about to open our mics. I just want to remind you of a few things. healthyseminars.com/resources. You can see what's coming. You can see what has come. We have a whole resource section, so check those out. This talk will be up there for you to review as well. The website, if you're looking for continuing education credits, the coupon for the 25% discount is Healthy25. All live webinars for CUs are currently discounted at early bird for the month of May 2020. You guys are great. I love your questions. The community unity stuff is amazing. I'm doing a workshop next week. You can watch the intro on laurenbrown.com on the whole mind body stuff. And we have several talks coming up on post-traumatic stress disorder and anxiety, because, this is something that we are trained for. And I know this is something, for example, that dry needling cannot treat. Emotional stuff, right? This is where our principles come in. And so there are several courses in the upcoming live webinars geared to help you support your patients on that emotional level, which Chinese medicine understands, appreciates, and respects the mental aspect on how it affects the physiological part of the body. So do check that out. Thank you, Dr. Valerie Hobbs. Thank you, Dr. Steve Shomo.